Anosognosia affects 50% of all people with psychotic disorders. So we're talking about half of the people in this country and around the world who have these illnesses don't know it. And the biggest predictor of not being in treatment is having anosognosia.
There is a real sense in a lot of places that they don't really consider these to be life-threatening illnesses because you can't see them and somebody isn't bleeding. But at the same time, the mortality rates are very high. I mean, these are real illnesses that need to be taken very seriously.
So many get advice to do interventions, to confront the denial. So people are actually very actively dealing with the wrong problem. And this person has anosognosia. They don't understand. And they cannot understand when they're symptomatic. My brother was in treatment for 18 years and never believed he had schizophrenia. And when I asked him, so why are you taking these injections of antipsychotic medication if you don't think you have schizophrenia? And he said, well, I do it for you. So what was his answer? He did it for relationships.
Well, I want to welcome you, Dr. Amador. It's great to have a chance to just do a quick introductory meeting here and kind of talk about what we've been privately talking about for many months now and just kind of discussing. I mean, you and I both get very excited whenever we talk about this project. So it's really nice to be able to finally roll it out for folks and introduce you in this capacity and talk a little bit about, just kind of as an overview, what your relationship with TAC has been over the years and with Dr. Torrey. So first of all, obviously we're an organization that has always had a deep connection with loved ones that have SMI. Right. And so I was wondering if we could just talk a little bit about what your personal connection is. I mean, I think most people know about your brother and what have you, but just wanted to give you an opportunity to talk a little bit about your very personal connection to this issue.
Sure. I mean, I have several personal connections. My brother is the one I can talk about, but I actually have two other relatives one who has schizoaffective disorder and one who has schizophrenia. My brother Henry, when I was 21 years old, had his first episode of schizophrenia. And Henry and I were always really close. And he was my rock. We immigrated from Cuba. My mom came alone with 4 kids. And I was the youngest, and Henry was 8 years older, and our father had been killed in the revolution. So it was a really scary time. We moved to the Midwest, to Ohio, and Henry was my best friend, taught me how to ride a bicycle, throw a baseball, and most important, Lisa, he listened to me. I was an anxious little 4-year-old, And when he got ill, that relationship, that close relationship, kind of went to hell in a handbasket. And it simply has to do with anosognosia, this unawareness of illness, because I saw he was ill and he didn't see
he
it.
was 20. You said he was 21?
I was 21. He was 29. Now, in retrospect, he'd been getting ill for about 5 years. Mm-hmm. And I know a lot of families have encountered this where the person starts to withdraw. They stay home. They drop out of school. They stop working. So he had about a 4-year, what we call a prodromal period, where he was sliding into psychosis. But then there was a tragic event in our family and full-blown florid psychotic symptoms, delusions, hallucinations appeared. And I went and I talked to him and I said, look, you really need help. Let's go get some help. And we argued for a week. And like so many families, I ended up having to call the police because he was suicidal and getting him into the hospital. So I have real intimate experience with this. I have a very happy ending to the story in terms of my brother's recovery. But we struggled for like 7 years. We fought over that question. Does he have a condition? Does he have a mental health condition? Does he have an illness that would benefit from treatment? And from his perspective, absolutely not. I'm not sick. I don't need help. Leave me alone. You're the crazy one, not me. I heard that many times. So I have a very intimate experience with this. One of my kids also has schizophrenia and is also doing really well. So I have a lot of very personal connections to it.
So obviously, anosognosia is kind of your main area of expertise, although you're obviously well-versed in many other things. I wondered, what was your experience like in, when you encountered this with your brother? Did anyone talk to you about anosognosia at the time, or how did you go about finding out about, hey, this is a thing, there's a name for the thing that we're experiencing right now?
This was 1981, and the first researchers to ever propose that what we're seeing in schizophrenia might be anosognosia was me and my colleagues 10 years later. So of course I didn't hear about it because I hadn't really kind of discovered it or proposed that this might be what we're seeing for another 10 years. And it wasn't until about 8 years after my brother became ill, I was working on a neurology inpatient, a neurology ward. And I was evaluating a person with paralysis. He was paralyzed on one side of his body. He didn't know it. And I was evaluating his anosognosia, this unawareness of neurological deficit. And I'll never forget, I mean, he was certain he could move his arm, even though I showed him that he couldn't. I asked him to move it. He couldn't move it. I was certain that he was going to see it. Just like I was certain if I kept talking to my brother about his schizophrenia, he was going to see it. And working with this neurological patient, just like a light bulb went off in my mind. And I thought, this is exactly what I've been dealing with my brother Henry. And by that time, countless patients that I've been working with on inpatient units who were presenting in exactly the same way. Nothing's wrong with me. The family is very concerned. Everyone around the person says they have illness, and they're certain they don't. So it was that connection between a neurological patient reminding me so much of what I've been dealing with as a family member.
Given that anosognosia is observable in some settings, I mean, like you could definitely tell if somebody can't perceive that they can't move their arm, but they believe that they can. Right. You can kind of see that. And, I realize that it's a little bit different with people with severe mental illness because it can look like simple denial. But why do you think it's been so difficult to kind of get the professional world that handles treatment and care for severe mental illness to kind of accept this as a thing that is observable?
It's a great question. And I've scratched my head a lot thinking about it over the years, because after that paper in 1991, where my colleagues and I suggested what we might be seeing is frontal lobe deficits producing this unawareness of illness. Within 3 years, people started studying it. Within the last 30 years, we've got dozens of studies showing neuroanatomical differences, brain functioning differences. And yet, like you just said, the field still is slow to embrace the facts, the scientific facts that anosognosia is a real thing. The reason for that, I think, is it has to do with history and a rush to judgment. Psychiatry right through the 70s was really dominated by psychoanalysis and psychoanalytic theory. And in psychoanalysis, I read the books actually about psychotic denial. This was deep repression. And that's still being taught in some medical schools, that this is repression, this is denial. So there's really, kind of an inheritance of a concept, a rush to judgment. And so people are slow. The other reason is we all know people in denial. We might even recognize times when we've been in denial, right? And like, oh, geez, I've really been denying that I'm drinking too much. And it's more commonplace than seeing somebody with a neurocognitive deficit that leaves them unaware.
I wonder sometimes if we want to think that on some level, I mean, not necessarily you and I, but if as a society, we want to think that way about it so that it isn't a thing that we have to act on. We'd like to say that this is a choice that somebody's making. And because that, maybe lets us off the hook a little bit for having a responsibility to do something.
Lisa, I don't think there's resistance to anosognosia and kind of a reflex to think of it as denial because people don't have to do anything. Because in fact, I work with a lot of families to this day, and so many get advice to do interventions, to confront the denial. So people are actually very actively dealing with the wrong problem. They're dealing with denial, and they're alienating their loved one. They're creating, traumatic experiences. Well-meaning, they're trying to help, but because they think it's repressed knowledge, they think it's denial, then they do what the show Intervention does, which is they gather the whole family together and they tell the person, you're sick, we're worried about you, you're ill. And this person has anosognosia. They don't understand, and they cannot understand when they're symptomatic. So I don't think that's the reason. I think it's because we encounter denial every day. We see it on the news. We see it in our friends. We see it in our coworkers. We see it in ourselves. So it's just a commonplace thing. How many people have encountered somebody who's paralyzed on one side of their body and they don't know it. Well, I have.
Good point.
I have, and I've seen it, and it's profound. And then you think, well, what's the research? What do we know about schizophrenia? We know that executive function, frontal lobe deficits produce this, what looks, walks, talks, and quacks like denial, but it's not. It's a neurocognitive deficit. It's another symptom of the brain disorder, just like a delusion.
So what does happen when, when people take this, when they accidentally take the wrong tack and they're coming after, they're like doing an intervention with somebody who has anosognosia? What happens when that tactic is used?
I've seen people end up homeless. They run away from their family. I've seen people get really angry. And if I take their perspective, understandably, because I have my whole family telling me I'm sick and I know that I'm not. So estrangement is the short answer, really significant estrangement. Again, I work with families who haven't talked with a family I worked with last week, hadn't talked with their loved one for 6 months because they did an intervention, and they regret it and they feel really bad about it. But they were coming from a very loving place. They just were working on the wrong problem. They thought they had to bust through denial instead of engage with their son and create a relationship with him.
Would you say that's kind of similar to what people experience when they try to have an argument about whether a delusion is real?
Oh, yeah, right. So if somebody's delusional, and that's one of the first things a lot of us as family members learn, and as a clinician in training, don't try to talk somebody out of a delusion. You can't. It's right. By definition, it's a fixed false belief. It's fixed. It's concretized. So, the attempts to talk people out of delusions it just doesn't work. So same thing with anosognosia, trying to convince someone they're ill. If you've been trying for 6 months, 3 to 6 months or longer, to show someone that they have a psychiatric illness, and in particular, in this case, we're talking about psychosis, like schizophrenia, and they're not getting it, you're dealing with a symptom. You're not dealing with denial.
So do you kind of see it as being like a light switch that's either on or off? You have this awareness and you can perceive these symptoms at some point and then it switches off, or is it kind of gradual, or are there times when it's more possible to reach someone?
Yeah, and it's another really great question. Anosognosia is like any other symptoms of any medical disorder or brain disorders. Symptoms wax and wane. So some days the person, as the anosognosia wanes, may develop some insight, some awareness. And everybody gets really excited and happy. And then 2 hours later, they're like, no, there's nothing wrong with me. The research is over time, anosognosia tends to stay pretty stable. It'll wax and wane, but over the course of years, even when somebody's successfully treated, let's say the hallucinations and delusions are successfully treated, they still don't understand they're ill. My brother was in treatment for 18 years for most of the rest of his life, and never believed he had schizophrenia. And when I asked him, so why are you taking these injections of antipsychotic medication if you don't think you have schizophrenia? And he said, well, I do it for you. And for mom and pops. These are Betty and James who owned and ran the home that he lived in. So what was his answer? He did it for relationships. And so when somebody has anosognosia, we actually, when we know what the root of the problem is, that it's not denial, it's anosognosia, we don't do interventions, we don't do education, we don't do teaching. What we do is heartfelt connection and engagement and work on the relationship so that you end up with a scenario like I did with Henry, with my brother.
And I would assume that was kind of what led to your development of LEAP, was just kind of trial and error and sort of figuring out, well, if we accept that this is not denial, if this is anosognosia and we know what we know about that, these are the things that we think might work. Would you say that was, kind of how you happened upon LEAP?
Oh, yeah. I mean, I was insane. Einstein's definition of insanity. For 7 years, I kept doing the same thing over and over and over again. Henry, you're sick. Henry, you're ill. Henry, you're having hallucinations. You need medicine. And expecting a different result, and I never got a different result. That's Einstein's definition of insanity. I was insane. It was an experience I had in my training, in my internship year with a patient just like Henry, and my supervisor said, Javier, stop talking. And so I stopped talking in our supervision session. He said, no. He said, stop talking to her, start listening. And it's just sort of this fundamental, who needs another psychologist to tell you listening is valuable? Well, here I am. I learned to listen. I shifted. And I went back out into, I'll never forget this, going back out into the day room. I said, can I talk to you again? And I apologized for telling her that she had a diagnosis and she needed medication. I sat back and said, why don't you just tell me what you need? And she said, I need to get out of the hospital and I need to get my mother to stop calling the police. And we started working on that together. And that did lead to her accepting treatment. And even outside the hospital, I saw her in clinic afterwards. So that was another epiphany. And I called my brother and I apologized for all the times I told him he had schizophrenia. And I promised I'd never do it again. And I also apologized for all the times I told him he needed to be on medication. And I promised to never do that again. And with that shift in how I spoke with him, which was anchored in listening and empathy, within 6 months, he accepted treatment that he stayed on for the rest of his life. And it has to do with me understanding the problem and then changing how I approach it.
So with that, kind of queuing up, I wonder if you can give us like a real brief overview of LEAP and, kind of what it is and like how it's kind of a different way of coming at this from what people might try if they were, not aware of the program. And just, and because I think we can get into it in much greater detail in another episode, but just to give people an overview would be really helpful.
The real quick overview is this came out of a study that Aaron T. Beck, the father of cognitive psychology, Dr. Beck and I had a grant to do a short-term psychotherapy intervention with patients who did not understand they had illness. And I lifted from that psychotherapy that we came up with a communication program. So LEAP stands for listen, actively and reflecting what the person said without judgment, empathizing very strategically and normalizing the person's experience. So listen, empathize, find areas where you agree, and that's what you partner on. There's 3 other communication tools, and one of them is about how to give your opinion, because you do want to give your opinion. So LEAP here's what it sounds like. Let's say you had schizophrenia, and you and I were friends, and I was talking to you, and I wanted to talk to you about your illness, and you said, there's nothing wrong with me. I'd reflect that back. So what you're saying, Lisa, is there's nothing wrong with you, right? Okay. It must be frustrating. Now I empathize. It must be frustrating for you to have these conversations with me. Yeah, I'd be frustrated too. Now I'm empathizing. And maybe you start talking about the CIA surveilling you and why that's your real problem. I would actively listen. I'd reflect that back. So Lisa, your real problem isn't mental illness. Your real problem is the CIA, right? Did I understand that? And how do you feel about that? And I empathize with your feelings. People get scared to do that because they think they're going to make the delusion worse. You cannot make a delusion worse. Just like you can't talk somebody out of a delusion, you can't talk them further into it. However, when you're using LEAP, sometimes the person you're trying to help thinks you agree with them. And you do give your opinion. You do very humbly say, I'm sorry, I could be wrong, but I don't see the same evidence of the CIA that you see. I hope we don't have to argue. Those are 3 components to the opinion tool, we call it. Mm-hmm. So LEAP has 7 tools. It's a communication program. It grew out of a psychotherapy. We teach it to anyone who wants to learn it. So family members, mental health care professionals, criminal justice professionals, judges, parole officers, probation officers, police officers, first responders. Anybody who encounters somebody with anosognosia for a mental illness can benefit from. I'll share what I said to myself, which is shut up and listen, and then you win. And I think anybody can benefit from just pausing from talking and start listening.
I can really see how it would be really useful advice, especially because I have absolutely been in that position where, somebody is talking about something that is a delusional belief, and it is really tough to know, without having a strategy, am I going to be doing any harm if I sound like I agree what's going to happen? Or if I, kind of let them go down that road, am I doing any harm? So it is good to know that you're like, as long as you have the opportunity to say, well, I don't really see it. I mean, I'm going to just respectfully disagree that I don't see the same things that you see. It just gives people that tool. I can see how that would be such a relief to have just a playbook to go by.
Yeah. And you know who it's a relief for also? Is the person suffering from the mental illness who has anosognosia, because these are the loneliest people I've ever met.
Yeah.
Everyone around them thinks they're ill. They know for sure they are not. And they're constantly in battles and struggles with loved ones, with police officers, with crisis workers, with doctors. And so when you can listen to their experience, the things that are most important to them, they've been chosen by God to do miraculous things and heal people. I want to listen to that and talk with them about the thing that's most important to them, that grandiose delusion. I won't call it a delusion. And they may make the mistake of thinking, I agree. And I'll give my opinion when the time is right. You know, I'm sorry. And the part that's really important is that we should apologize, because when we give our opinion, it's hurtful to the person. So I'm
Well,
sorry. It could be
I
wrong.
definitely think that like part of what's at work there is that nobody wants to think that if they have a health condition, it's their entire identity. And if it's the only thing that you ever talk about with them, then it's like they're walking around with the name of their diagnosis on a shirt and it's their whole identity. So, I mean, I mean, why would anybody want that?
I wouldn't.
So I'm wondering if you can talk a little bit about your history with Dr. Torrey and like how you, because I know you've known him for a very long time and you guys go way back. I think everybody would love to hear a little bit about, kind of your relationship and, where you've talked about things over the years, where you have found a real meeting of the minds.
Well, I've always admired him. When I was in training, I admired him a lot, and read his papers and books. So I was at a it's called the Schizophrenia Winter Workshop Conference in Switzerland. I had a Young Investigator Award, and that flew me to Switzerland. And I got to meet all the experts in the field. I was in my very early 30s, and Dr. Torrey Fuller and I were on a chairlift together. I found myself next to this person I idolized on a chair, and we're talking. And he's, what Fuller's like. He's a very kind, generous with his time person. And he asked me about myself, asked me what I was doing, and I shared that I was working on this paper, and I had this idea that what we're seeing isn't denial, it's anosognosia. And he lit up. We got off the chair and we started talking. We're not going doing any skiing. We're talking, and he said, "Apply for a grant with the Stanley Medical Research Foundation." He said, "It'll come to me." And I said, "Well, how long is the application?" He says, "One page, just what you just told me on the chairlift, and make sure you reference it with research." And that was my first real grant. That's bought me my first computer when I was at Columbia University. A young psychologist allowed me to hire my first research assistant and launch my career. So Fuller, I'm so indebted to him, not for that grant, although certainly for that, but for his encouragement, his belief in me and in my hypothesis. It was just an idea way back in 1991. And that evolved into a good, close friendship. I mean, I love Fuller. He's an awesome guy. And
I think he's played that role for many people over the years. Yeah. I mean, and not just professionally, but, I mean, I run into people all the time that have had these amazing one-on-one interactions, and he remembers them 20 years later. They might reach out and he will remember. And I think it's just interesting how complementary what you have done is with what TAC has worked on and what Dr. Torrey has worked on. And just like, it's like, if we're out trying to persuade the world that you need to think about this differently, then I think of you as being somebody who's out there trying to show somebody what to do with that information and how to make lives better.
Yeah. Well, I remember the launch of TAC. Fuller and I were together with a third person. He asked me to present on anosognosia. And it was at a NAMI conference. And afterwards, people just lined up to talk to us about anosognosia, about the whole idea behind TAC. And that was the beginning of a long relationship in terms of working together on this problem. And there are different approaches to this problem. The approach, of course, that I focus on the most is befriending the person who has this condition, connecting with them so they're less alone, and then influencing their behavior so they do choose healthcare over living under a bridge.
Yeah.
It doesn't always work, and sometimes we need to do other things, but But that was the genesis.
Exactly. I mean, and I think that's one of the things that if I could get across one thing about treatment advocacy center to people that I want them to understand is that, we don't want to use involuntary treatment as the first option either. It needs to exist, needs to be there as an option if it's necessary. But there are a lot of options that you can try first. And LEAP is one of those things that I think people feel great about knowing that it's there for them.
They do. And when it works, it feels like magic because you have somebody like my brother who says, I'm not ill. There's nothing wrong with me, but I'll be involved in treatment. My brother went to a clubhouse, didn't believe he had schizophrenia. And I said, well, why do you go to the clubhouse? He said, those mentally ill people are really nice. I mean, he didn't see himself as having a mental illness. They're really nice. They're really nice people. He had good close friends. He had a girlfriend. He had 2 volunteer jobs. I mean, he really enjoyed recovery. It really brought home for me the importance and the value of investing in the relationship. And it's really scary and it's really hard because your loved one is talking about things that make no sense, that are scary, and entering their world is how we can help them come back to our world.
So one thing I wanted to talk about a little bit is, so we're, our partnership, what we're going to be working on is going to be a lot focused on educating people about, what science do we know? What does the research say about various things? There's lots of topics that I think people are always wanting to know more about because due to HIPAA, we often can't get that information from the physicians that are treating our loved ones. I'm wondering so I know that you come across family members all the time. What would you say are some of the things that they are the most eager to know about, that they, maybe are not hearing about from the actual physicians that are treating their loved ones?
Well, how to handle HIPAA is one of them. and there's a lot of good common sense advice that me and other people have learned over the years, how to negotiate HIPAA so that you can be engaged in your loved one's healthcare. Certainly the treatments, not only the pharmacotherapies, the medications, and some of the, at least one of the very unique medications that's underutilized, but also things like oral versus long-acting injectables. A lot of families I present to have never even heard of long-acting injectables. And the research behind it is that people stay in treatment much more often if they're getting injections once a month or once every 3 months than if they're asked to take, pills or tablets. So they want to know about treatments. What about non-pharmacological treatments like psychotherapy? Well, there's a really good evidence base that cognitive behavioral therapy for psychosis helps with many of the primary symptoms of psychotic disorders. So treatment, HIPAA, how to stay engaged, how to keep your loved one out of the criminal justice system. If they happen to get arrested for a misdemeanor crime, how can you divert them from jail to healthcare? And there's lots of really best practices that we'll be talking about in terms of how to make that happen.
What would you say are some of the, developments that have happened in recent years that are the most exciting, kind of areas on the horizon that you're kind of, what is going to happen next?
Well, talk therapy is evolved in a really exciting way. So CBTP, cognitive behavioral therapy for psychosis, transcranial magnetic stimulation, those studies are going on where magnets are used to stimulate neurons and neuronal circuits so that it's very targeted treatment. It's not systemic, where when you take medications, it's in your entire body. It does cause side effects for many people. Those are 2 things that really stand out. The other, though, is learning approaches like LEAP, how to engage people in treatment. So motivational interviewing, LEAP, and the ongoing research in those areas are teaching us that, anosognosia affects 50% of all people with psychotic disorders. So we're talking about half of the people in this country and around the world who have these illnesses don't know it. And the biggest predictor of not being in treatment is having anosognosia, right? So that research is really exciting to me. Double-blind placebo-controlled studies of LEAP and other approaches that are similar that always really start with entering the person's world and validating their experience. and then bringing them back to our reality.
I know
not to convince them. Not to convince them that they're ill.
Right. So you and I have talked about how, it is actually kind of unusual to find people who are, psychologists who are, kind of interested in working with this group. I wonder if you have any thoughts about like, what's the best way that we could go about trying to persuade more people that this is rewarding, that there's a reason to do this, that you should focus on this population?
It's immensely rewarding because, when I help somebody come out of their isolation, come out of their anger and frustration with their family and everybody around them because they know they're not ill and everybody thinks they are, and are able to influence them to accept treatment and they enter recovery. It's so much, I don't know if I want to do the comparison or not, but it feels more rewarding than when somebody comes to me and says, hey, I've got these symptoms, can you help me? Because the person who's coming to me for help already is engaged with other people. People with anosognosia are isolated and alone, in my experience, and so reaching somebody, building a bridge to that isolated, lonely person is immensely meaningful and gratifying. And how do we get people to see that? We need to have people who have been through periods of anosognosia, because there are people where the anosognosia does resolve. It didn't resolve with my brother and in many patients, but in some people it does. So hearing from those people what it was like. Fred Fries, who's passed away, Fred and I, Dr. Fries, would talk about the period of time that he did have anosognosia early in his illness. So Fred, not only did presentations, we did presentations together. He testified in front of Congress. For clinicians to see somebody who's been through it and realize, don't give up. This is not the difficult patient.
I remember Fred had a great line that he used to use, and I just loved it because it was perfect. He would say that you should absolutely never treat somebody involuntarily unless they need it. Which was great. I mean, and I think people, it's important to hear from people who are affected by involuntary treatment. It is not a uniform population. People's experiences are all over the place. And there's a lot of people who are grateful for the intervention, just like there are people who are not. Yeah. It's definitely important to remember that we're talking about individuals. There's no one perspective that applies to everyone.
There's no cookie cutter approach. There really isn't. No.
So I wonder, if you have some thoughts about some topics that you'd really like to cover as we sort of launch our podcast series and we kind of work on our collaboration, what are the topics that you're the most interested in kind of talking about and, discussing with the people who are watching us and kind of want to know how to bring what we're going to talk about to their lives?
Helping people to understand the causes of psychotic disorders. There's a lot of self-blame that goes on, the genetic and the environmental causes, and for example, insult to the developing fetal brain, head injuries, exposure to virus during, in utero. So understanding causes, understanding the range of treatments that are available, pharmacological and non-pharmacological. These are things I definitely hear about a lot from families and would definitely want us to talk about and educate. Most importantly, in the spirit of LEAP, I want to hear from people. I want us to get requests for topics. Another one of the topics I definitely want to encounter is and respond to is how do I help my loved one, live independently? And there's so many pathways and there's so many things we can do to support someone to move from basically being warehoused. I hate to use that term, but it's really what it looks like. Just getting medicine and nothing else, to engagement in meaningful activity, whether it's volunteer work, paid work, going back to school, socialization. I want to talk about psychosocial rehabilitation as well, and helping people to regain some of the social skills that the illness took away from them. There's cognitive remediation. So one of the array of symptoms that we see in schizophrenia and related disorders are cognitive deficits that aren't, the main symptoms. So things like working memory problems and interventions to improve those cognitive deficits that are associated with the disorders. So this is off the top of my head. I can think of many more things that people ask me about. Whenever I do a presentation, I get a dozen questions that are coming from all the directions that I just went in.
Absolutely. And I know when you and I have talked about, kind of how we envision the collaboration and what we are interested in, we always get very revved up and kind of talking about all these topics that we're really interested in covering. And I think it really points to just like a lack of that being available. Like no one's really talking about this information. It's available if you work in the area, but anyone who's affected by severe mental illness wants to know. I mean, just like if I was diagnosed with diabetes, I would want to know all of the things that I need to know about, like, what are my options and what makes my prognosis better or worse, and what other things do I need to worry about? And I think it's a real, kind of gap area for what we work on in the space of mental health advocacy, that we don't always think about. What would you want to know about if you were in the situation, if you were a family member who was just encountering, these initial psychosis symptoms? What would you want to know? What would help you to navigate it better?
And importantly, my North Star is, what do you want to know that's science-based? Facts versus myths, evidence-based. I mean, I'm going to be happy as we go forward with this collaboration to share my clinical and my family experience, but I'm always going to start with, what's the science tell us? What's the reliable, replicated science tell us? I won't be talking about just one study. I'll be talking about science we can take to the bank.
Do you feel like it's like we've kind of, when we talk about mental wellness and we talk about mental health, do you feel like we've sort of gotten away from that, where people kind of don't recognize that? I mean, certainly there are a lot of mental illnesses and there are conditions and there are diagnoses that are maybe situationally influenced, but that, maybe we forget sometimes that some of them are not that way. Some of them really are. You do need to understand the science and the medicine behind it.
Yeah, you do. And there's a lot of misinformation out there. There's a lot of myths. I mean, I remember when I resigned from Columbia University and a director of psychology to work in the advocacy space. So I went and joined NAMI as similar kind of position that we have going now. And one of the first things I did was review all the literature, and the literature was just based on myths. This is 24 years ago. But, the pharma industry had told us that the second generation drugs were going to result in better compliance, better adherence because they had less side effects. Well, there was no science to support that. And the rate of refusal of treatment and dropping out of treatment is the same, whether it's Thorazine or Haldol, the first generation, or the newest drugs. So understand it. For me, it's really important that when we do this together, that we rely on the science. Because as a scientist, as somebody who's done a lot of research, what I find is the research gets stranded in the ivory towers, gets stranded in the journals, and doesn't make its way to the people who need it. You, me, families, clinicians, policymakers, criminal justice professionals.
I feel very similarly about the getting caught in the ivory tower on the legal side of things. I mean, obviously my training, I'm an attorney, and I guess I've said before, and I guess what I think about how we ended up with the system that we have, such as it is system, it's kind of, we've sort of built a system.
There's over 50 systems.
Right, a patchwork. I always feel like what we've done is we've built a healthcare system, or a patchwork of systems that's based on the clients that we would like to have rather than the people that we actually have.
Yeah, and back to your earlier question about how do we interest clinicians to work with the population of people who have anosognosia. Just remember, for every person that walks through your door, there's somebody who's isolated alone in a bedroom or homeless living in their car. And how meaningful and wonderful it is to help that person, re-enter life with other people. For every person that walks in the door willingly, there's somebody out there who needs you. And most of us got into this field, whether we're psychiatrists, social workers, peer specialists, like, I'm sure I'm leaving some people out, counselors, because we want to help. And too often we're so focused on the person in front of us who's seeking help that we forget there's as many people who aren't asking for help but need it just as badly.
Yeah, I've always thought that that's part of why it's hard to change the philosophy that you need to wait for somebody to hit rock bottom and come to you. Is that it's? I think there's something about the idea that you want to feel like somebody wants your help, so you don't want to go out and try to impose yourself on somebody who's not looking for help. But if you do that, there are huge swaths of people who are just invisible to the system, and yeah, some of them might eventually become voluntary patients and they might come seeking care, but some of them may not survive long enough to do that. And they matter too.
Many don't. The mortality rate by suicide in schizophrenia and bipolar disorder is mortality rate by suicide is 10%, roughly 10%. So the possibility of dying from these illnesses and not being in treatment is the biggest predictor, is higher than most forms of cancer. So leaving somebody, to hit rock bottom is just unfathomable to me. It doesn't make any sense.
It's one of the things about kind of our emergency system and our triage system that has always been frustrating is that there is a real sense in a lot of places that they don't really consider these to be life-threatening illnesses because you can't see them and somebody isn't bleeding. But at the same time, it's, the mortality rates are very high. I mean, these are real illnesses that need to be taken very seriously.
Yeah, and life expectancy is less if you have schizophrenia. And
a lot less.
Yeah. I mean, these are real serious medical conditions that affect somebody's, heart and soul. And every person that you and I are focusing on and talking about right now, the patients with this symptom of anosognosia, I think it's fair to generalize all of them want to be befriended. They want to be loved. They want to be cared for. And I know it may sound a little touchy-feely here, but in my experience, and it is the most meaningful thing about working with people like this, is when I can befriend them. And I teach psychiatry residents and clinical psychology students, and I often argue you can love your patients, you can befriend your patients, you have professional boundaries, but you can care deeply about them. And when you do that, they're much more open to the things you're suggesting they do.
That makes me think of kind of some recent articles that I've read about moral injury that has been discussed amongst professionals about how the way that we have set our system up is creating a kind of de facto situation where professionals aren't really able to help people and they watch them suffer, and it does something to them, to not be able to do that.
Yeah, no, I've experienced that because I don't always succeed, and it's brutal, and certainly family members experience that, and my hope is that with what we're doing together here, this collaboration, we're going to give families a lot of hope and real tools, things they can use to help their loved ones, and knowledge they can use to influence the healthcare of their loved ones, to penetrate HIPAA, to communicate with their loved ones' doctors and prescribers.
Well, I definitely feel that families
I've got some secrets on how to do that.
I love that. Yeah. People will be thrilled. I mean, honestly, we come from the position that families are the unsung heroes. That like our entire system is based on their unpaid caregiving support. Yeah. Without any, not even enough education, or there's certainly no financial support. There's not a lot of, there's no real outreach efforts to try to help them figure out how to navigate systems. So whatever we can do for families, that's the reason why Treatment Advocacy Center exists.
Yeah. Now, families are on the front line. They're the ones who spend the most time with the person.
Yeah. I always think about, I was in Virginia once giving testimony, and I can remember that there was a mother who came and was giving testimony. She was in her 80s, and what she was talking about is that she was terrified to die because she had no idea what was going to happen to her loved one. And I think about that all the time. We have got to create a system that is able to care for people, even if their families are not able to do it for them. You cannot assume that everybody has a family that has the capacity, financial or emotional or whatever else, to actually do this. And it's something that needs to be all of our responsibility.
Agreed. Agreed. And a little caveat, in the families I work with, this comes up frequently. And that fear of when I'm gone, what's going to happen to my son or daughter. And engaging friends and siblings who have pulled away is one of the things that we do. That still leaves the family and friends on the front line. And I know you're talking about a much broader safety net that we do need to make happen. But too often it falls on one or two parents' shoulders, and the rest of the family doesn't, is scared off, frankly. So there's ways to engage people, and that's one thing I hope we'll talk about.
Emotionally, it is devastating, but it's financially devastating too, to try to navigate this. So I think the more people understand what the real hurdles are, the more likely we are to alert people to the situation that you can't have an entire area of healthcare that is dependent on unpaid family labor.
Right.
Well, so I want to just kind of throw out there that I think our plan will be that we're going to be creating a line that will be open for people to kind of voice their questions and kind of talk a bit about their own situations and get your opinion. The number to call to submit a question for Dr. Amador is 703-294-6005. And again, that's 703-294-6005, which I know is very exciting. I mean, whenever I have seen something like that offered, there is always a flood of people who have got some really serious questions. And I think a lot of that is going to guide, what we are going to be doing, because like we talked about, what we really want to do is we want to provide people with what they need, and nobody can tell us what they need better than people who need something.
Right. Well said. Yeah, and I'm looking forward to getting the questions. And there's going to be times when I don't have the answer off the top of my head, and it's going to make me go and do some research and talk to colleagues. So I'm excited about that, really.
Yeah. I mean, I'm hoping it gives us a lot of opportunities to really highlight other people who work in the field, who, there are so many areas that people don't know the work that others are doing. I mean, I'm always amazed at how few people actually know about the psychological treatments that can really help people do better with, the overall quality of their lives. And I hope that as we make that available, people will know what to ask for, and they will know what to go out and, be advocates for themselves and their loved ones about this is what we need and this is what we should have.
Right. Yeah, I think when we are active in advocating and not passive patients, healthcare is always better.
Well, I have really enjoyed having an opportunity to have our initial conversation here about our collaboration. I think that people are going to be ecstatic to have an opportunity to hear from you more often than they are able to just like tune in every week and see what we're talking about and what you're able to bring to the table and who you want to bring in to discuss things with.
I'm excited to bring in colleagues, people with lived experience, family members, and leaders in our field. I'm really looking forward to this. It's going to be fun.
And it's going to be wonderful.